Okay, more or less we're almost everyone back here. Well, thank you for support me through the for the first 2 hours and to being able to go through the first 2 hours. Let's see if we can make this part in 1 hour and 15 minutes so we get for lunch not so late. These two lectures go about this one is kind of similar to the last one that we had, but now centered on what happens in the abdomen. And the next one will be what happens with patients with neurological problems. So this one I made it a little bit different. In this one we are gonna meet Max, who had a real bad problem on his GI tract. So he came us with a septic abdomen, jejunum perforation. As you can see, this was an old guy, miniature schnauzer. He was 13 years old, male castrated. And this is what we found in surgery. There was a hole in his intestine, in his jejunum, actually, is what we found. So this dog had a kind of a not very much history that the owners could give us. So it was just this kind of maybe an IBD. He got some steroids at some point during his life, has some diarrhea. Maybe there is a history of foreign body, but we actually did not get very much information from the owners on this. So we had to approach this just like a septic abdomen, no, and then try to fix it in surgery and see what happens. It could be similar the history of Max to Fosca. It's a GDB post-op surgery patient. So the complications that both are going to have to face in the post-op period are pretty similar, are not that much different. Arrhythmias are going to be there, sepsis is going to be around, problems with fluids and how the glycocalyx is able to keep the fluids in. It's also going to happen in patients like this. So it's not so much different. So I decided to take Max for this lecture because when I was doing the lecture, actually we have Max in the clinic. So we were treating this patient at the same time I was doing this, and this was over the last 2 weeks. So one of the most important messages of this lecture, and I think for emergency medicine in general, is that if you want to have less complications in the post-op, your pre-stabilization needs to go well, and you have to focus on that. This is a mistake that we all make because we are in a rush. The patient needs to go into the surgery, into the OR, sorry, into the surgery. So we all try to rush things, and sometimes we just don't even think for a moment what we are doing. No, how much fluids are we giving to that GDB? How are we trying to fix the septic abdomen? We all know that that patient needs surgery, so the fixation is in surgery, but it really matters if you give the antibiotics before surgery. It really matters if you give painkillers, fluids, how you get that patient into the OR. Something that has developed over the last years, and I was talking about that in the first lecture, is the damage control surgery. Damage control surgery means if you cannot get the patient stable enough in a period of 1 hour or 1 hour and a half, and the condition that he has is surgical, get him into the OR and continue the stabilization of that patient. That's something that the vets still we don't have it in mind. Now it's growing more that concept, but we usually just go into the OR, try to fix whatever is in there, and even, or maybe because we don't have the resources, we don't have the people, we don't pay that much attention to continue with the stabilization of those patients during the surgery. So that's a big problem that we most of the time see, and something that happened to Max as well during the post-op. Many complications can happen, as I was saying, and most of them are systemic consequences that these patients have after surgery, and not necessarily are related to a surgical problem itself. It's just the stabilization and the underlying condition of this patient that put him into surgery. So in this lecture, and giving importance to the GI dysfunction that we can have after abdominal surgery as the main source of the problem, probably you are aware, and with advanced affinity and other lectures you have read about the microbiome. I don't know if it's that the right pronunciation in English, but how the bacteria of the intestine play a major role on what's going to happen in the rest of the body, how is our microbiome working, and how this GI dysfunction is going to impact our patient. Again, you're going to see this slide through the entire lectures. Initial evaluation of these patients is not any different from the other ones that we have talked about, so I'm not going to spend that much time. But remember, volume status, look for arrhythmias, get your blood pressure, see if the patient is hypoxemic or not, and do a minimal evaluation with a blood sample so you can see in which state are you starting to treat this patient. So this guy, Max, went to surgery because he had a septic abdomen. And after the surgery, and I'm talking about after the surgery because it's what the lecture is about, this is what we found. This patient, right after the surgery, as soon as he was coming back with the stretcher to the ICU and all the blood pumps were beeping, beep, 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 and was getting to us, his heart rate was 180, his mucous membranes were pale pink, his mean arterial pressure was 55, his temperature was 34, his SpO2 was 93%, and he has quite of abdominal pain. So it was a little bit of a mess. And it's not the blame or fault of anyone. This guy they just did the best that they could for this patient, but he was still in trouble. When we took a blood sample, his PCV was 45, but look at his solid was 3.2. Normally it's higher than 5.5, no? So he was really had low proteins. His lactate was 3.4, and the lactate has to be lower than 2.5. So some sort of bad perfusion to his tissues was happening as well. His glucose was not so bad. It was maintained between the range of 80 to 110 or 120, so it was not so bad. Do you work here with the glucose in milligrams or in millimoles? Milligrams? Okay, good. So where do I start with Max? Why he seems to be hypovolemic, and asking your question before, how many losses we have on this guy, where the proteins went if they are really low, no? And what fluids should I use on this patient? These are the questions that start to bump in your brain with this one. The fluid loss on this patient is from the third space. He has GI problems. He has a bad peritonitis because of the septic abdomen. And the hypovolemia, he is going to be a challenge because this guy has a problem in the intravascular compartment, in the interstitial compartment, and all that mesh of hairs that I was talking about, the glycocalyx, is probably going to be messed up. It's not going to be right. So the more fluids that you put, the more crystalloids you give to this patient, is going to make him more and more puffy and more jiggly through the hours. But at the same time, you have to do something with this, no? So considering that this patient is septic and we want to avoid the fluid overload as much as possible, so we will have to be careful and consider this level of proteins, no? Initial approach that we took on this patient. So we started with a classic bolus of Ringer lactate of 10 to 20 mils per kilo over 15 minutes and reassess the hemodynamic parameters and warm the patient. We warmed the max up to 37. We got the heart rate and the mean arterial pressure to get better, but they quickly fell again. So we were seeing like a transient response on this patient. He was on the compensated side of shock state, but we couldn't get those fluids too much on his intravascular compartment. So he seems that he likes the volume, but solids are 3.2, likely will benefit from oncotic support. How I'm going to give this oncotic support to this patient, no? Would be synthetic colloids a good option? This patient is septic. We were talking about acute kidney injury, synthetic colloids in one of the papers. Maybe it's not the way to go on this one. I advanced that to all of you before, no? This would be the options that we have. We can give this patient fresh or stored plasma. And most of you probably will wonder which one is better on these cases. The fresh will help you if the patient has coagulation problems, because it will give you all the coagulation factors that he needs. But if you are only looking for proteins, the stored plasma is way better and it's cheaper. So you can use that option for this patient and save some money if your blood bank can supply you with this. So this is something that sometimes we just use for this patient, is a little bit cheap. We blood type them. Yeah, we blood type them. So this is another question that many times comes up and has been debate for many years. Do we need to blood type these guys or no? We know that the blood typing can help these patients to decrease the reaction transfusions that they might have. It's not that they have in a plasma transfusion many red blood cells to give these patients a reaction, but we can have cross interactions and make these patients sensitive. So it's always advised to blood type these patients, especially if you are dealing with a cat more than a dog, no? How to use the plasma? Let's say that Max in this case needs the plasma and we are going to give him. So the concept that I want to transmit to all of you on this is we have been used to transfuse blood or plasma slow, no, and see the response that we have on the patients because we don't want any reactions. When the patient is dying in front of you, that should go apart and just focus on the patient. If your patient is dying, there is no time for a test dose. There is no time to go on zero 0.5 and then on 1 ml per kilo over 15 minutes. Just throw the blood or throw the plasma into that patient and see the response you have. He might die, maybe, but not that doesn't happen very often. He probably will die from what is happening in there, okay, and why he's hypovolemic. Yeah, that's the good part of the critical care, honestly. They are almost dying in front of you. So just do something. Do something because he's gonna die no matter what. So don't spend your time or waste your time doing a test though. Just go and try to get this patient stable. Is a dog? Fantastic. Blood type? Maybe that we don't need that. We don't have time. Just give negative plasma. You have a cat? Okay, spend few seconds doing your blood typing, and if not, just guess it's going to be blood type A and give blood. Okay, that's pretty much the way we do it when they are dying in front of us. But with the plasma, you can do a bolus of 5 or 10 ml per kilo or 2 ml per kilo if you want, and you will get these patients more stable. Once you get the fluid bolus or the plasma bolus on them, and is moving into the intravascular space, then you can just slow down as long as the patient gets better. Okay, this will save you time, but don't spend that much time just doing all your test and compatibility testing. If things are not going well and something happens like this one, okay, I have plasma, but the plasma is in the freezer, so I have to defrost the plasma, and that's gonna take me 20 minutes. But Max is dying now in front of me. What I do? I'm not gonna give synthetic colloids because Luis said it was bad for him, so I'm not gonna do that. Holy moly! Now what? Go with vasopressors. Try to save some time. That's something that you can do. Start norepinephrine or dopamine or whatever you have in your clinic. If you, well, whatever you have, no. Start with dopamine or norepinephrine, but give a vasopressor. Don't go with adrenaline because that's going to be too much for his kidneys. But norepinephrine is the vasopressor of choice that we use for septic patients, and that's the dose that we use, I think is on other slide, is 0.1 up to 2 micrograms per kilo per minute. So if you have a dog like Max that seems to be volume responsive, but is transient, his solids are low, he seems to be shocky, and the pressure is not getting any better, and you want to give the plasma, in the meantime that you defrost the plasma, start with the vasopressors, and as soon as you get the plasma ready to slam in him, give him a bolus of 2 or 5 ml per kilo. So you will see how he starts to respond. Maybe he will not respond as fast as you want, but you will see a trend on how he's getting better. When this happens, despite crystalloids, plasma, vasopressors, heart rate are not improving much, that can happen as well. And it's just a reflection not of the bad job that you are doing. It's just how sick the patient is. Don't get frustrated with that. You are doing as much as you can, but dogs are sick. And this is just the natural progression of the disease. What else should you think? What are the other options you might have in there? So if you are, you don't need to be a radiologist or a person with a lot of experience to get an ultrasound like this one, but just take a quick look of the heart. If you see something that looks like a bladder instead of a heart, that means that heart is just not contracting very well. Okay, this is a dog with a dilated cardiomyopathy. So you can see the chambers are really dilated and there is no almost no muscle in here. So if you get a image like this one, or maybe you cannot get the patient any better, and you don't have an ultrasound, but things are not getting better despite all of this that you are doing, your next step should be something like this, and think about if this can be happening. No, septic cardiomyopathies that we know exist, and is transient on his nature, but it will take at least, or it can take to the dog 48 hours to get through it. When you are using vasopressor, maximizing the fluid volume that you are giving in terms of blood transfusions, blah blah blah, and things are not getting better, the dog still is tachycardic, choose one of these, pick dobutamine or pimobendan as a inotropes. So you will be working with norepinephrine at the same time, and something that will give you some support to the contractility of the heart. That might help that patient to get through the instability that he has for now. If you start any of these products and the tachycardia gets worse, put it out. Okay, don't use it. I mean, if you have tried the ultrasound and you don't get this image, or you just don't have it, and empirically are starting this, and the doctor starts with a tachycardia, then this was not a good idea. Okay, it was just a trial. You tried, it didn't work, so it's not on the table anymore. What else should you think in these cases? And this is the question that you have before. No, this dog Max, for example, had a kind of a sketchy history of steroids that he was receiving on and off, on and off. We didn't really know, no, but at some point, this dog had developed some dependency of steroids, or in not the case of Max, maybe any other one that you might have, allergic dogs. How many dogs we see that are on steroids for allergies, no? So maybe that dog that is dependent on that dose of steroids that we have given for a long time, now that he's sick, we are not giving him that dose that he needs. So it's something to think about. It's not something to jump on very, very fast at the very beginning of the emergency, because you can have consequences of high doses. That's the hydrocortisone arriving to the treatment. So, but it's really something to think about, because it also happened to me in the past. So don't worry that this is something that happens. So think about this. Don't use dexamethasone. Maybe probably it will be too much for the dog, but if you can get hydrocortisone, you will give physiological cortisone to that patient, and make at least will help him a little bit more. Over the last years have been very, very fashion, and this is not on the lecture, to start what is called the sepsis cocktail. Sepsis cocktail is something that has been also pulled out from human medicine, and is this tendency is led by a very important intensivist in human medicine called Paul Marik, and he found and published that in 40 patients with really bad sepsis, combining vitamin C, thiamine, and hydrocortisone, he was able to get these patients through the sepsis. So over the last 2 years, we have been all crazy going through that treatment and putting patients like Max on all these 3 therapies. Before, I mean, when I was writing these lectures, one paper came out, and it was just putting away that theory again. So we are back to the beginning, where we don't really know if new therapies will really help to sepsis or not. But so far, the hydrocortisone is accepted on these cases when we have patients that are hypotensive and not responding to the therapy, or we have patients that have been on long treatment with the steroids and suddenly get sick. So 3 hours post-surgery with Max, he seemed a little bit better. He had a heart rate of 120 with a sinus rhythm with occasional BPCs. His mean arterial pressure was not so bad. It was not 80, but it was in the 72. So anything that is over 65 is fine. But he was dependent on norepinephrine and dobutamine. His urinary output was decent. His SpO2 had improved. His PCV was 41. His solids only had came up by 0.4, but better than 3.2. And his lactate that was 3.4, it was down to 2.9. I forgot to put it on this lecture, but I mentioned before, lactate clearance or clearance of lactate is important in septic patients and can give you an idea if this dog is going to survive or not. If they are able to decrease the lactate by 50% in the first 6 hours, you are doing good. If after 24 hours the lactate is high, is really bad for them. But suddenly, this is what happens to our friend Max. Let's see if I can. Okay, so everything seems to be okay, but this is intensive care, so this is things happen. No, so we have a patient with ventricular tachycardia with a heart rate of 185. His mean arterial blood pressure came down to 63. So that was not really good for him. And what do we do now for this patient? So these are the options that you should have in your brain, and probably you know all of them. Either lidocaine or bolus. When lidocaine doesn't work, go or jump to procainamide. And when you have no idea what to do, just to start with sotalol to try to get things a little bit more under control. The question here is always the same. Was it justified to treat on this patient? Should I think on something else? So what are the criteria to treat ventricular rhythms? So heart rates over 180 causing clinical signs, and a clinical sign could be just the hypotension that he was having, and with a heart rate over 180. So yes, it was definitely worth it to treat. Polymorphic BPCs. So when you get BPCs that look different, one to one side, the other to the other side. So in these cases, yes, you have to treat them because this is putting the patient on more risk. Or when you have this phenomenon, R on T effect that you can see here, this is just the preclude, or is not the preclude, is the beginning of the badness that is going to happen, and the badness is the ventricular fibrillation the patient is going to experience. So with any of these criteria on the table, then yes, you should treat the patient with lidocaine. This is how Max responded to what we did, sorry. So something happened here, but it was still looking pretty bad, no? So it seems Max had a partial response to lidocaine, but now what? No, can I do something else for this dog? So yes, lidocaine really depends on how your potassium is in the bloodstream. So if you are not looking at the potassium and just slamming and slamming more lidocaine on this dog, probably you will not get the effect that you want, and maybe you can have either lidocaine toxicity, or if his liver is not working well, you can get him into trouble. So just check that your potassium is fine. Your potassium needs to be between 4.5 and 5 to get the maximum effect of lidocaine. And this is something that we forget. And we just say, oh, the potassium is fine, it's 3.7. All right, it would be fine for a dog that doesn't have this problem. But for this one, you need to do something different, no? And on the first lecture, I gave you a little chart on how to supplement potassium. And this is what we did on this one. So something else that we can do, magnesium sulfate is another thing that plays a role on ventricular arrhythmias, and is one of those therapies that we don't keep in mind. This is very cheap. It doesn't cost more money than lidocaine or any other product. And when you have a patient like this one with this ventricular rhythm and your potassium is not getting any better, magnesium sulfate can do the magic and get the potassium get into the cell and reestablish, so it starts to go up. So this is published in Veterinary and Critical Care Medicine. We use it, and this is something that the dog can be on magnesium sulfate for 24 hours, for 48 hours, as long as he needs. Okay, but it's kind of a mixed treatment with the lidocaine, knowing that your potassium is fine, and if you are not getting things any better, then start him on magnesium sulfate. Other uses for lidocaine, so for example, patients with GDV, probably you have heard about this study. It was very famous over the last years, and it was told to us in this study that if you give them lidocaine before the stabilization, even before the fluids, you can avoid multiple organ failure on those patients, because lidocaine has the magic for pretty much everything. So has antioxidant effect, has analgesic effect, has antiarrhythmic effect. So it's just magic. So something to consider as well on patients with GDV. Continuous assessment of this patient. So Max remained stable through the night. We all went home, although he was looking this crappy, honestly. So he was pretty sad, but he started to be established through the night. So we kept him with Ringer lactate with potassium chloride with this fluid plan. We put him on AMPI and Enro until we got our cultures back. So right after the surgery, he was on fentanyl CRI, norepi, dobutamine, maropitan. That was pretty much his treatment for the first night that we have him. Next morning, you get back to the clinic. You have been on the phone pretty much now all the night with your resident, talking about how is the patient doing, blah blah blah. And on physical exam, we found Max to be hemodynamically stable, but he had peripheral edema on his limbs. When you do the skin test, he was very jiggly. He was a little bit uh, overloaded. He had marked melena, and he was quite nauseated on abdominal palpation. So our blood tests from that day show that the PCV was 32, his total solids were up to 4, his lactate came down to 1.5, his glucose were 52, so this started to go down. His creatinine was zero point 0.7 and the initial was 0.5. Remember that I told you that if it jumps 0.3 or more than 0.3 in 48 hours, that kidney is not happy. And we saw as well that his PT and PTT were markedly prolonged. His drain production, that the one that he had in the abdomen, was producing 12 mils per kilo per day. We want this to be less than 5, so it was producing quite a bit from that drain. And on the abdominal ultrasound, his stomach was really, really distended. No, probably that was why he was so nauseated when we palpated his abdomen. So how do we address the coagulation defect, the hypoglycemia, the melena that this dog has? What do we do now for him? Because he already got a bunch of things, no? More plasma on this case is what we use for his coagulation problem. And we also started with tranexamic acid, something that I was explaining to you before, that can at some point help you on these patients with melena. The oncotic support here was basically to win the vasopressors that were still given to him. So it was still on norepinephrine and the dobutamine that we were working through the night. So basically that's what we did for his coagulation defects, and just supplement him with dextrose as you would do for any regular patient. No, just be careful with central lines. I mean, when you need glucose higher than 7.5, it's not that you cannot use this through a peripheral line for a long period of time. But if you are planning to give dextrose for more than 6 hours, then think about a central line. I mean, probably most of you have been in the situation that the dog needs more bolus and more bolus and more glucose, and then the theory is that you have to place a central line. Okay, that's not going to happen at the same time that you are giving the fluid bolus. No, you need some time. So I've been doing this for many years on a peripheral IV catheter, and not so bad with a peripheral IV, at least for 6 to 12 hours, when I cannot get a central line for whatever reason. And as long as you implement and get more control on that peripheral catheter, things can go well. And most of the time, I'm able to win the 7.5 down to 5% or 2.5 in less than 6 hours, saving the patient to place a central line. That would be another discussion. On emergency and critical care, we love to put tubes in holes. That's what we do pretty much all the time, and we record whatever is in a screen. No, so I'm more on the side of doing all that is necessary. And central lines, I have seen many disasters just to trying to be ahead of things, and this means thrombus, air embolism, bleeding problems, patients with vena cava syndrome. So just put central lines when they are really needed for that animal. Okay, no more tests and no more tubes are better medicine in these cases. So just calm down a little bit on the situation, evaluate the whole patient, and then place it if you really need it. After this break of apology about this, let's move on what happens with our friend Max. So hyperglycemia can be a problem in a septic patient. Yes, actually we know that it can increase the mortality. So try to get control between 80 and 180. Do not take actions of prevention if the patient is not showing hypoglycemia. Just get control of what's happening. And if he gets hypoglycemic, then supplement him. If he gets really hyperglycemic with no dextrose, just manage him as you would do with a diabetic dog. Put him on insulin. I mean, you can tolerate 180, you can tolerate 200, but you cannot tolerate 300, 350 for many days because the dog will get into problems, okay? But try to do something that is reasonable between 80 and 180 because otherwise the possibility of death is increasing. Gastroprotectants indicated in cases like this. Probably you have heard about these guidelines, no, that are published. We have all free access to them. When it's needed, it's needed. And if this dog is bleeding in the GI tract, then go ahead and give it. There is no problem on doing that. But if the dog doesn't have any bleeding tendency, doesn't have an ulcer, doesn't have any other underlying problem that justifies to give gastroprotectants, there are actually studies saying that the gastroprotectants like omeprazole or pantoprazole can select for bacteria that will kill your patient. So this is more in the human medicine side. We're just translating that to our medicine. In our case, with a patient like Max who had melena, who was on a high risk of bleeding, then yes, we put him on omeprazole at least for the next couple of days, no? But bear this in mind because we give too much gastroprotectants many times, and we just mix medications that are just bothering one to the other. And the typical one is clopidogrel with omeprazole. The omeprazole will not let the clopidogrel to work. So be careful with this because we tend to do it quite a bit. So our friend Max needed 3 units of plasma. His PCV dropped to 15%, needing 1 unit of packed red blood cells. So I'm just giving blood products and more. What are the risks we are assuming with a patient like this? Massive transfusion can be a problem. Massive transfusion is when you give a patient his blood volume in less than 24 hours or half of that in 4 hours. So when that happens, you can get, as a main problem, I would say ionized hypocalcemia. We are giving so much citrate that is on those blood bags that his calcium will be chelated by the citrates. So if you get a patient with hypocalcemia, it will happen what it happens with bitches after delivery, that they start to seize and be quite clumsy. It would be the same thing that happens to them. As well, the coagulopathy can get better with the citrate, so just be careful with this if you don't pay attention. Excessive sampling. This is a problem that we have more in cats than in dogs, and this paper was published in cats. But when you are facing dogs that need, or cats that need so much care after a surgery like this one, be careful because you can bleed them to the point that he will need transfusion. And this is published in cats that if we take samples up to 3 mils per kilo, not per day, just on the entire hospitalization of those patients, they will need transfusion. That's what we know from this study, okay? So what to do for these cases? Just try to put the schedule for the blood sampling on these patients in a reasonable manner, like 2-3 times a day, and just take as little as you can to do your blood test. Okay, don't go crazy, just trying to check things all the time. What can we do for nausea and ileus in these patients? So this is basically what we have. Antiemetics, prokinetics, and then feedings are important for abdominal, for any critical care patient actually, but for the GI actually will help quite a bit. What can we do with antiemetics? So a multimodal approach is what we really like to do when things are not going the way we want. No, we know that the vomiting center will get inputs from many different parts of our body, and what we have here, the receptors that we have here, are dopaminergic, serotoninergic. We have the neurokinase as well in there. So using a multimodal approach will help you. Maropitan can kill many nauseas and vomit, but sometimes maropitan is not enough. So you need to add other sort of therapy. Ondansetron is another one. Metoclopramide is another one. How good is metoclopramide in cats or is in dogs? For the vomit is not great, but as a prokinetic can help you on these patients. All depends on the dose that you are using, for example. Antiemetic strategies, I've left you here these ones. something that I really like for these patients is to place a nasogastric tube and just decompress the stomach. And this is something that to me makes sense, because when you vomit, actually you feel very released. No, you feel much better after you empty your stomach. If we can do that for them and help them, like this cat, I don't know if you appreciate the nausea on this cat, but this was but quite impressive on this little cat. With a nasogastric feeding tube, or the nasogastric tube, we were able to decrease his nausea quite a bit. So I usually like to use it, empty the stomach, and trend how much fluid is in that stomach. So if the patient is getting more than 10 ml per kilo, what I do is to increase the prokinetics that I'm giving to this patient. I think it's on the next slide, no? The prokinetic strategies. So it will help you to make the patient to feel better. Be careful and don't suction too much. I mean, twice a day is fine, but don't go nuts and aspirate more than twice a day, because you can create a patient with a metabolic alkalosis that can be really bad. Okay, so do it a couple of times a day, and if your accumulation of fluid is higher than 10 ml per kilo, give more prokinetics. Which ones you can use? So metoclopramide, we are used to use it going back to the other slide, as an antiemetic between 1 and 2 milligrams per kilo per day. That would be the antiemetic dose. But if you want to use it as a prokinetic, and that's basically the good effect that metoclopramide will have on your patient, the dose can go as high as this, 4 to 8 milligrams per kilo per day, and not necessarily your dog or cat will get into one of the extrapyramidal effect. Okay, and I have been doing this for many years, so I feel quite comfortable doing this with patients. Erythromycin is another decent prokinetic. It depends on the literature that you read. I honestly, when I have a dog or a cat that cannot control the vomit, I don't care very much about the literature. I just use what I have. And this is what we have in the clinic. So erythromycin I have been using with decent results, and it's not so bad. So if I cannot control the vomit or the nausea, I just jump on it and give the chance on that patient. And many times I will tell you that works, okay? But don't take this as a religion. Not all of them will have a good response. Cisapride will be another one. And this one, if you can move the patient, this is the best that you can do. If they can actually go for short walks, it helps. Just think about yourselves after Christmas dinner, no? How you feel, you feel that you're pretty, what can you do? You just go for a walk and try to move your body. No? This will actually help you to get things moving a little bit more and get the patient a little bit more or less nauseated. No? So our friend Max was started on metoclopramide CRI. We went up to 3 only, and now she was controlled. After transfusions, we were able to stop Narepi and the dobutamine CRI. Maybe be the time to think about feeding on this patient. And this is a good point. Please also debate on this, but the right time to start feeding is when the patient is not vomiting, doesn't have any nausea, and is not on vasopressors. That would be my summary for when I start feeding some patients. I have tried to do it in the past when the patient still has nausea, when the patient is vomiting. I mean, 1 vomit you can tolerate, 2 vomits you can tolerate, but if the patient is just actively puking, that's not the right time to start it, neither when the patient is still needing vasopressors, because the perfusion to the GI tract is not very good. So wait a little bit, and when you get these things under control, usually 2-3 days, then you can start to feed them. And this is something that I like to put on the lectures, because this comes from the biggest human medicine, nutrition, let's say, organization. No? And they say, well, if you have a patient that needs to be fed, enteral nutrition is the preferred route. Something that we agree. No? We prefer to use that route over parenteral nutrition for the ill patient. If early enteral nutrition is not feasible or available for the first 7 days following admission to the ICU, no nutrition support therapy should be provided. So in human medicine, according to these guidelines, we're going to starve for 7 days, and we are not going to be fed for 7 days if we are not able to be fed by enteral nutrition. They are not going to use parenteral unless you are really sick and you have a body score condition that justifies to start parenteral nutrition. So if you are a person with decent reserves that probably any of us in this room can be, then you will not be fed for 7 days, which is quite impressive, no? But in veterinary medicine, we know that we can get into trouble, especially in cats, if we are flirting with more than 3 days for cats, no? So then is when we start to get nervous, and our guidelines move more between the 3 to 5 days. So when we reach that point and we spend more than 3 or 4 days with a cat or a dog that is not eating, then it's time to think actively on how to implement the nutrition plan on dogs. And actually there are many papers out there that say that feeding these dogs as soon as you can, or these cats as soon as you can after surgery, improves the outcome of them. And by feeding them doesn't mean that you have to give them full RER. The requirements don't need to be the highest. You can just start with a 10%, 20%, and see how is the response. And if they are accepting the food, then you can go higher on that. 16 hours after we started feedings, and it was 3 days post-op, my resident sent me a picture of Max drain. And this was yellow, chicken yellow. This is not good. And no, this is not going to be good. The bilirubin on this fluid was up to 30 milligrams per deciliter. Normally it's up to 0.5, 1 if you want the most. And his bilirubin in bloodstream was 1. So it was really not so bad, and it was pointing that something was happening inside his abdomen again, no? Something that probably you have seen many times, complications after surgery. Also on the cytology, there were mixed bacteria. We diagnosed a bile septic peritonitis, and he went back to surgery. So what are risk factors for the ESANs after surgery like the one that Max had? So these patients definitely are on a high risk. On this study, they use staples instead of hand sew sutures. And they show that the staples were better than the hand sew technique. But also in other studies, we have found that patients with IBD, previous to the surgery, patients that experience hypotension on surgery are the ones who are more likely to fail on the anastomosis or on the surgery that you made. So that is when it comes important, how was the stabilization of the patient, how you got that patient into the operating room, and how things went during the surgery and in the immediate post-op. So this is something that unfortunately happens. Our friend Max survived to the second surgery but developed an intense abdominal pain. His creatinine started to raise after surgery. What was happening? This is something that I want to talk to you because not many people keep this in mind. And the abdominal compartment syndrome is something that happens, something that I put on the first lecture. If you imagine one of these legs when they have an abscess and they just start to swollen, and then you start to see this leaking around the leg, just no, you are familiar with that situation, no? When an abscess is just about to explode and it's just leaking and leaking and leaking. So just to translate this to the abdomen, this is the same. The compartment syndrome that you have in the leg would be similar to what is happening now in the abdomen. So things are getting swollen and swollen and swollen. And what happens in here is that your abdomen starts to not being able to accommodate your organs. So it starts to compress the vena cava, so the volume that gets to your heart is less. So the stroke volume and all the fluid that comes out to the heart, from the heart, to the kidneys and to the liver and to the pancreas decrease. So your perfusion to the organs just go down. And this is something that we have to bear in mind because it's very simple to measure the intra-abdominal pressure and to take actions when this happens. So just imagine for a second the patient is here on this area of the slide. The only thing that you need is to place a Foley catheter in the bladder. You empty the bladder and then fill it with saline. And once you fill the the bladder with saline, this system is connected to a scale that will measure how the intra-abdominal pressure is on that patient. It's technically very simple. is this, the scale is something like this. This patient is not Max, is another one who was hit by a car and had a hemoabdomen. But the scale that we are using is this one. And what we are doing is to connect the Foley catheter through this three-way stopcock to the scale in here. And basically what we are doing is to compare the pressure that is inside the bladder against the pressure of the atmosphere, and we get a value. So it's technically cheap, it's easy to do, and it's something that people don't pay attention. But when you start to see pressure that go high, and high is more than 10, is when you realize that your patient is in trouble, and maybe that's the reason why your creatinine is going up, or your liver is going up. So this would be the diagram to explain how your system is starting to explode. No, your guts get very edematous, your pancreas get edematous, your aorta is still intact because it's muscular, but your vena cava starts to be stretched, so you don't get all the fluid that you need to pump through your heart. This would be the diagram, and it's a little bit shocking when you look at so many arrows in here. But if you look at these, just the big parts, when the pressure in the abdomen rises, you have vascular compression, your diaphragm gets pushed against the lungs, and you get organ compression. All of these, forget about this for a moment, translates in decreased cardiac preload, decreased cardiac contractility, and your afterload goes really high because everything is compressed, right? So your abdominal perfusion pressure goes down to the toilet, and your kidneys, your liver, your stomach, your intestine just starts to fall apart. Your suture maybe will fail because you have an increase in abdominal pressure, and so on. No? So you can see a lot of complications if you don't control this part. These are the guidelines that have been used in human medicine. Big summary of this is, if your pressure is over 12, try to get this patient stable with fluids, analgesia, decrease or empty. If there is fluid production in the abdomen, just drain it. And after that, if the pressure is still high and you have done all of these and you cannot get the patient any better, then you have to go to surgery. So basically, it's just that. Okay, if it's over 20 and you have maximized all of this and the patient is not any better, you need to go to surgery and decompress the abdomen. Decompress the abdomen, most of the time, is just to place a drain. That's it. Okay, we don't go now with surgeries that means to open the abdomen and let it unswollen for days and days with the open abdomen. We don't do that very much these days because of the complications, but just placing a drain can help you to decrease the intra-abdominal pressure. How can we get max better? So these are the same options. Added to this, epidural injection or catheter is a good option if you have a patient that is not hypotensive, but if it's hypotensive or coagulopathic, don't think about that because you just will get into trouble with this. And this happens because you will block all the nerve ramifications at the level of the thoracolumbar space, so you can get this patient really vasodilated. Other options, diffusion catheters after surgery that can be placed, and these are other options that we are using in the late days. Instead of NSAIDs, we use Bipron, metimazole, paracetamol. Paracetamol, don't use it in cats, don't use it in dogs with liver disease, but if that's not the problem, then you can use it. Okay. Antithrombotics, going back to the question you had before, no? This is definitely a population that is at high risk of thrombosis. The decision, again, should be based on every single patient. Right after surgery, I don't usually put them on this. I usually just wait and see what the tendency is. On Max, I didn't use it because he was actually bleeding. So he had melena, he has his PT, his PTT, his platelets were low. So there was no reason to put him on this unless I wanted to get him on more trouble, no? But if you are going to choose one because the dog is really inflamed, this is the dose that we use, either dogs or cats. You have it here. Okay. So at the time I was writing this guy was recovering from surgery. This was him right after surgery. Well, right after surgery, no. But maybe it was, I don't know, 16, 20 hours after the surgery. Now I know what happened at the very end. At the very end, this patient had to go back to surgery again. So it was a third surgery because through the drain was not bile any longer coming. So it was feces that were coming through the drain by that time. So we ended euthanizing this dog on the third surgery because there was no option to connect again that intestine. The tricky part of this case was that this guy used to do this, would look like shit for a few hours, and then he would be like eating and walking, and it was just like, well, we had a biopsy pending. I will tell you the result now, but he would look fine. So the owner always wanted to go back and go back and go back. When we had the result of the biopsy, this guy was suffering a tremendously bad IBD. So his full intestine was just so inflamed that there was no option to connect it. And when we went to the third time to surgery, even with the staples, there was no even one zone of the intestine that was healing. So there was no reason to keep going with that biopsy, and a dog that was not doing well after all these surgeries because that was the third one. And we know that the prognosis for these guys after the second surgery is not going to be very good, no? But this could have had another ending, and maybe this dog could have, been through the surgery with all these steps that we did. And actually, the proof is that he usually recovered well after surgery. The problem was the underlying condition, and this is something that we also have to take into consideration, no, when we are treating this patient. How salvageable, how manageable is. I mean, I can fix the patient now, but what is the prognosis? How it's gonna look like? No, give them always a chance, but sometimes you also have to know when to stop. With these guys that does this is the most difficult part of our job, because when they look like this and eat, it's always hard. No? So this would be the conclusion. Thank you very much, and if you have any questions, I'm happy to take it. Thanks. Okay. So this one is what happens with neuro patients when they are hospitalized, not necessarily in an intensive care unit, but when we have them in our hospital, and what sort of complications we might have with these patients. No, maybe this little one that was beaten in the face or in the head. Sorry, the same that happened to this was beaten in the head and in the thorax. This is how we ended. So what all these patients have in common? No, spinal trauma, brain tumor. So what they have in common is that many diseases that they have make these patients prone to very bad complications in the meantime that we have them in the hospital. And most of them can only be prevented or immediately detected to be treated. We still have many problems in terms of resources to treat these animals, although we can still do quite a bit of things, for these patients. This is a Labrador, 50 kilos or 52 kilos Labrador. Can imagine how sore is my back after that one, because the people that work with us is not very tall, so I was the tallest one that could help to to change the position of this dog, and this dog suddenly went into tetraparesia. As you can see, he was very stiff, and this is the kind of dog that is just a mess when you look at him, and with so many options to get into trouble, that the only thing that you can do is to try to prevent. Every time that this dog would wake up from his sedation, he would be just screaming, would be getting pretty hyperthermic, like 41, 42 degrees was just kind of regular for him to get like heat stroke all the time. So we have to keep him quite sedated. But when you have a dog sedated like this one, what you are just doing is to buying tickets for aspiration pneumonia, for example, or to get whatever complication he decides to do, during these days. This another one is a really sad story. This poor little guy went to the ophthalmologist because he had ophthalmologic problems, and they did at the vet clinic some sort of surgery that I don't remember for the eyes. The conclusion is that, or the consequence is that he went blind. He was blind at home for a couple of days after the visit at the clinic, and the owners have a terrace, and I think he lives in the fourth floor. So he just fell from the fourth floor and broke his spine. And broke his spine to the point that there were no reflexes. There was nothing from, I don't remember, it could be from any side in between T3 and L3 where he broke his spine, but the owners wanted to go ahead with this patient, no? Also a problem for him because they don't understand how sick they are, no? They get really worked up, blah, blah, blah. So we can have a lot of complications happening in any part of the neurological system, brain, brainstem, T3L3, cervical, any part of these, and even the bladder can be a problem with these patients, as you will see later. So this is what we are going to talk about in these next 30 minutes of lectures. What happens when we have dogs like this, intracranial disease, no? This poor one, or what you can recognize on the face of this one, this dog is the classical teckle that, or teckle is a breed in here? Yeah, you understand me, right? Okay, good. So this poor dog was just barking through the bars of his house, and a pit bull came across and just pulled him through the bars to the other side. So his face was just smashed, as you can see in here. His intracranial mess was a really, really mess, no? And this guy was a meningoencephalitis that he had. What they have in common is that they are prone to develop increased intracranial pressure and a depressed mentation, no? All of them with, doesn't matter if you have like a tumor here, there is a hemorrhage like the one that you see on this one after being hit by a car, or is something that you can see here. That depressed mentation will put them, as the other one that is sedated, to many, many complications through the hospitalization. What happens to the brain? So the brain has the capacity to be auto-regulated, the pressure and the blood flow, let's say the blood flow to understand better the concept, between pressures that are in the 50s or in the 150. When this doesn't happen, then the dog can get into problem, or the cat can get into problem and be really upregulated, no? So if you look at this formula, this is the cerebral perfusion pressure. This is how much blood is getting to the brain. And you can see that this is a product of the mean arterial pressure minus the intracranial pressure. Any event that messes up with the pressure, or the mean arterial pressure and intracranial pressure, as hemorrhage, edema, or hypotension, will create a problem on how the blood is getting to the brain. So when we have that and our cerebral perfusion pressure is getting low, then we have that our brain doesn't get the blood that he needs. And at that time is when the brain starts to swollen, and when it's swollen, our pressure inside the brain or in the intracranial vault goes up. And when that happens, then we see consequences on our physical exam. This is a diagram on when the intracranial pressure goes up based on the intracranial volume. The highest it goes, the intracranial volume, the highest the intracranial pressure. That's pretty understandable, no? What happens in here is that the brain doesn't have the capacity to accommodate this. So at some point, it's going to explode because it doesn't have much more space. Something needs to happen in here to compensate for that. And this is what clinically you are going to see as the classic bradycardia and arterial hypertension. That is what is called the Cushing reflex. Before we get into the bradycardia and hypertension, we go through different stages. So you will see that when your patient is here, starts to be a little bit depressed. His mentation goes down. When it comes to this point, then he starts to be tachycardic and depressed. And when he gets to this point, then he's comatose and he's bradycardic and hypertense. So whenever you have a patient with intracranial disease, things that you have to look for definitely is to monitor the heart rate and the mean arterial pressure, because they are telling you how well your brain is perfusing and if there is being a problem with the intracranial pressure, okay? So if you go back to this formula, now that you have these little constants in here, the only way that your system has to
give the cerebral blood flow or the perfusion pressure to keep things moving. When this happens, if you have intracranial pressure that is going up, the only way that your body has to compensate is to increase the mean arterial pressure, okay, to keep the perfusion into a normal parameter. This is getting high because you have a hemorrhage, because you have edema, because you have a tumor, whatever consequence, no? And the only thing that your body can do is to increase the mean arterial pressure. And if that is the only thing that your body can do, what is your heart going to do? Slow down, right? And get bradycardia. So that's why when you get bradycardia and hypertension, you immediately in that moment have to think that that patient probably has an intracranial problem and you need to act. Is that concept right? Yeah? Okay. So, for example, Piper. Piper was like this when we accepted him. He had a meningoencephalitis, and he was quite of a normal dog, no? Quite happy. He would respond to different stimuli, and this is what happened during the hospitalization of Piper.
Paper. Piper, how are you?
I mean, if you haven't or you have not seen this dog before, I mean, you can say this is not normal. But if you know Piper, and Piper was just looking like this, you can tell that something was wrong with Piper, no? And if you know the story of Piper, that he is being treated for meningoencephalitis, then you can start to think something is really wrong on this dog, no? Maybe his intracranial pressure is not fine. So I should start moving on and checking on his heart rate, his blood pressure, because something is probably happening on this dog. And before it gets to the point that he's comatose and not responding anymore, I might should start thinking about mannitol or hypertonic saline or something like this, right? So this is how the damage progresses over time when you have increased intracranial pressure, no? You have a primary damage that you cannot treat, but what you can treat is the secondary damage and all the things that are going to happen here related to hypoxia or ischemia is what you actually can do with your clinical management. What are the most common and challenging complications of these cases? Intracranial hemorrhage, seizures, breathing abnormalities or apnea, depressed mentation. These are the champions of aspiration pneumonia. They love to have it, and this is reported in many papers, but the depressed mentation just put them over the edge to aspirate at some point. And it can be a silent aspiration. Not necessarily you will see these patients vomiting and aspirating the content. Other complications that they might have, acute blindness or game over, no? Those would be the options. So what do we do if we suspect increased intracranial pressure? What are the points? Look at this poor guy for a moment. This is another dog for a different reason, but also with an intracranial problem. So if you see, or if you can see this poor miniature schnauzer, it's not normal, right? This poor dog. This one was encephalopathic. This dog had a shunt, portosystemic shunt, and when he was getting into crisis of encephalopathy, his mentation would go just like this. This is another way to get increased intracranial pressure, not necessarily because you have a meningitis or you were hit by a car, but the treatment at some point is going to be similar. At some point in dogs like this, you are going to need some sort of hyperosmolar therapy. So what to ensure on these patients? Hemodynamic stability, just try to get them as much stable as you can with a mean arterial pressure over 80. Oxygen and CO2 need to be controlled on these patients. Just keep it simple. The higher the CO2, more vasodilation, increased intracranial pressure. Low oxygen, more vasoconstriction, less perfusion to your brain. Okay, so we need to get a control on the CO2 and oxygen just to keep them normal. That's it. Not more, not less, just normal. Okay? Try to avoid cervical compression on these patients. No jugular sticks. Don't put them on a collar or necklace. Don't use those kind of things. And just try to get the head a little bit up. 30 degrees, more than enough for these patients. Okay, if they are recumbent, just try to keep the head a little bit a line about 30 degrees, and that's it. And then, if you are not familiar with this, or if you are starting to be familiar with this is a scale that will help you to take actions and to make things more, let's say, reasonable in a fashion. No, when you treat these guys. So the modified Glasgow Coma scale will help you with patients that have the depressmentation or intracranial disease. And the only thing that you have to do is an assessment, a neurological assessment, where you look at the motor activity of the patient, the brainstem reflexes, and the level of consciousness. You can find this on papers, on books, or you can email me and I will send it over to you. But this is something that you can just do at your clinic. We have this printed and we just stick it on one of our walls in the ICU, because honestly I don't remember all of them. I just have an idea how it's going to move and what is going to be the value. But when I want to be accurate, I just want to and take a look at this. The value that you get is actually quite meaningful in terms of what you have to do in terms of hyperosmolar therapy or surgery or prognosis as well. And for that, you have studies like this one. This was published in 2015 with 72 cases. And that study told us that if the modified Glasgow Coma scale was less than 11, then the chances of that patient to survive were not very high. Okay, that patient was more prone to die. We have other papers talking about less than 7, and when it's less than 7, the chances to that patient to survive is less than 50%. So it's really bad. When the lowest it goes, the more chances you have to die. If the patient is hemodynamically stable, but the modified Glasgow Coma scale is less than 8, this would be the first step you have to take. On books, you will find the 3-tier, is how is it called, or tier. I don't know exactly the pronunciation of that, but let's say first step that I know how to pronounce that. So first step would be start hyperosmolar therapy and evaluate the response. And now the question would be, which one is better for these cases, mannitol or hypertonic saline? The eternal debate between intensivists and neurologists. And the answer, nobody really knows. If we look at the Brain Trauma Foundation traumatic brain injury guidelines, they tell us, you know what? Both might work. So you only have to pick one, either mannitol or hypertonic saline. Okay? These are the doses. Don't go lower than 0.5 grams per kilo of mannitol, because less than that, we know it's not going to make any effect on dogs and cats. So don't start with less than 0.5. My recommendation here will be, well, what kind of patient do you have in front of you? Do you have a polytrauma patient that has pulmonary contusions or a hemoabdomen and is not cardiovascular stable? Then use something that you know it's gonna give you the best of both things. So it will help you, the hypertonic saline, to stabilize the patient, at the same time will help you to suction some cerebral edema or hemorrhages that he might have. If you give to an unstable patient mannitol, you are not going to resuscitate him. Actually, what you are going to do is just to drain him more, and you will make him less stable. So in the scenario of a hemodynamically stable patient, I would go with mannitol. In the scenario of unstable patient, I would definitely go with hypertonic saline. When you use mannitol, remember, use a fluid filter. They love to make crystals. You know that, right? So use a fluid filter, administer over 20 minutes, get control of your serum electrolytes and bulimia, because after the administration, they are going to urinate quite a bit, and through that urination, they can get quite hypovolemic. And please don't use it if the patient is hypervolemic. If you have acute kidney injury and the patient is oliguric or anuric, you can get into real trouble with this therapy. What should we do if there is no improvement with hyperosmolar therapy and the Glasgow Coma scale is less than 8? So this is probably what we are going to need, to just intubate the patient and try to get the CO2 a little bit lower, okay? And try to get the PCO2 between 35, 45, normalize the oxygen or maximize to values between 80 and 120. and start thinking about MRI or CT scan because that patient is just not going well. If you don't have that option, but you know a referral place where you can send the patient, get him intubated and just translate yourself the patient. This happens to us in Spain as well. We don't have, I mean, where I work, we have MRI and we have CT scan, but sometimes we get patients that have been stabilized by the vet and they come with a pet to the clinic, bagging the pet, so with a bag mask. So sometimes it's just the only thing that you can do. And when you get into this sort of trouble, I'm not a neurologist, I'm not trying to be a neurologist, so I think when the cases get this bad, really you need help from them because probably that patient is going to need some sort of surgery at some point, no? So if that happens, it's kind of the 2 or 3 steps that you need is hyperosmolar therapy. If things are not getting any better, intubate the dog, control the CO2 and oxygen, and keep him stable. If that is not getting things any better, that dog needs MRI and probably a decompressive cremectomy. That's it. Either your client wants or declines that. If he declines that, then stop. That's it. No reason to continue. Okay? What if something like this happens? You get the patient intubated, you get your CO2, all is looking good, but look what happened to this dog. I got 15 minutes. Look what is going to happen now. So things are pretty smooth, are going well. Do you start to see what's happening in here? It's not just a shaky. These are my hands putting the diazepam in there because I know what's going to happen. It was the 3rd time that it was happening. Yeah, he started to have seizures. So do we preventively treat seizures? Not necessarily. We treat them when they appear. Okay, so this is something that has been a debate for a long time as well. So as soon as you have seizures, then definitely you have to be aggressive with them. But if you got a dog with traumatic brain injury, and that's the only thing that he has, putting him on anti-epileptic medication does not translate in an improvement. But as soon as you start to see something like this in a patient that is bad, then yes, you have to be aggressive and don't delay treatment. Okay. So this should be treated aggressively. These are the options. It's not very different to any seizure lecture or seizure chapter that you have read about this. We don't do anything different. We just consider how the liver is working in terms of can we give phenobarbital or not, and if we cannot, then we give Keppra. That's basically the big difference. And if we cannot get the patient under control with this, then we put them under anesthesia. So the patient is intubated, mechanically ventilated. Now what? So it's time for a big discussion with the client because we don't know if this patient is actually going to make it. Actually, things are really bad. But this is a question that many vets ask me. It's like, well, I got him in here. Now what? For how many hours? How long I'm going to keep this patient in there? As long as he needs. Nobody really knows. The rule of thumb that I was taught and the one that I try to transmit is if the owner has the resources and doesn't have to mortgage the house and can actually do it, give them 3 days. In 3 days, you will get an answer on how things are going. If this dog in 3 days made just a very slow recovery, but is getting better, you can tell the client this is going to take a lot of time. But things are so far not getting any worse. So maybe there is option as long as you got finances for this. But it's not going to be out the door and it's not going to be discharged in 3 more days. This probably will take a week or a couple of weeks or 3 weeks. Who knows, no? If the dog doesn't get any better or even gets worse, then you got your answer. It's time for considering euthanasia for this patient, right? But when you get patients like these, just keep them on the ventilator. How to put them on the ventilator? I mean, on long-term anesthesia, we use propofol CRIs, we use diazepam CRIs, fentanyl CRIs. Ketamine is not forbidden for dogs that have increased intracranial pressure, but has been a debate for many, many years as well. And we know that the only scenario where we can use low doses of ketamine is to keep them mechanically ventilated and under control. Otherwise, if you give ketamine to a dog that has an intracranial problem, then you can get things quite bad. So my preference, my choice, midazolam, propofol, fentanyl. That's how I kept this dog on the ventilator. Don't use isoflurane, allothane, any of these, because his lungs are going to suffer quite a bit and he's going to be quite hypotensive. And you're going to spend a lot of money on that as well, and it's not make things any better. Hypothermia is another thing that has been on debate for a long time, and it was kind of a fashion to keep these patients a little bit hypothermic between 32, 33 degrees. In human medicine, there is no strong opinion at this point in time. It doesn't seem to be advised because there is no a clear role on prevention of complications. And the main reason that hypothermia was brought up as a potential therapy was with the reasoning that will decrease the necessities of the brain in terms of consumption, oxygen consumption, and it looked that it could be a protective strategy for the brain. But now we don't have that so much clear. And there are studies showing that between 32 and 36 degrees, there is no much difference on these patients. So main ideas for intracranial disease is just monitor the heart rate, monitor for the hypertension, get these 3 steps very clear of hyperosmolar therapy, ventilation, and get your patient as much hemodynamically stable as you can, and try to prevent aspiration pneumonia when they are very depressed with the same therapies that we saw on the other lectures. Okay, I don't do anything different. There is no other magic drug for this. Spinal disease and polyneuropathies, I put them together because actually these recumbent patients, most of them just have the same sort of problems. Sorry. What we can have on these ones, and is quite remarkable on them, is hypoventilation, fever, pain, pancreatitis, the recumbency that put them again on these risks, micturition problems, and who knows, maybe deep vein thrombosis. Deep vein thrombosis, we know it happens a lot in human medicine and in humans with a spinal trauma, but this has not been reported yet in veterinary medicine. I'm pretty sure in the next years we'll see it. So our friend Risto, the one that you saw seizing on the other slide when he was on the ventilator, he was curious because he started that morning that we came to the hospital and we assessed him. Everything looked pretty good on him. We had a blood gas, the CO2 was fine, his oxygen was fine. He looked absolutely stable, but suddenly the nurse or the technician called us and said, hey, something is wrong. Look how this dog is breathing. And if you don't pay a lot of attention, his ECG is fine. Let's put it again from the beginning. What really changed on this dog is that he started to use his abdomen to breathe more than his chest. Do you see this here? He's just inflating and moving his belly, right? This is what started to change. And when we performed the second blood gas, when we saw this, we saw that his PO2 has come down to 63 and his CO2 was 57. So that was very different compared to the first blood gas that we had, maybe it was 45 minutes ago. So it was like no, this was before, yes. So on the MRI of this dog, we had a side of the traumatic brain injury here. He had a lesion on the cervical spine. The lesions on cervical spine can explain a hypoventilating or a hypoventilation crisis. And this is because the centers of respiration just go very close to the cervical vertebrae 3, 4, and 5. There is a mnemotechnic rule that I really like that says that C3, 4, 5 keep the diaphragm alive. And it's true, because when you have patients with damage of that segment of the spinal cord, these are the ones who can get really into trouble. And this applies to this dog and applies as well for the dogs that you see that come with localization between C1, C5, C2, C6. Any of these patients that come into the clinic with tetraparesia are definitely I wouldn't say prone, but they can actually have these complications. So this is something that can actually happen to them. And just remember this little song of C345, keep the diaphragm alive, to keep in mind that this is a complication that can happen. Again, this little monster with his hypoventilation that we were able to manage without without a ventilator, but just remember this sort of breathing, open mouth breathing in a dog is really supporting a hypoventilation process. Or maybe this one, or this one that is even more clear than the first one, where you can see how his abdomen, oops, is inflating. This dog did not have a problem on the cervical spine. This dog was after surgery of T3L3 hernia. And what happened to him is that his inflammation and myelation, his the necrosis of the medullary canal started to go up. So here is true that we have the centers of respiration, but don't forget that the intercostal nerves are also have innervation that comes from the space that is thoracolumbar. So if you get a patient that is on a post-surgical or post-surgery of T3L3 spine, be careful because this can also happen to you, and the dog can get into trouble because of the malacia of the spine. Okay, don't disregard them just thinking that it's not cervical, so this cannot happen. So when this happens and these patients get into trouble with CO2 really high, then they need long-term mechanical ventilation, as this little one that you see here. This guy was on the ventilator for 5 days and was euthanized after 5 days. It's part of our profession. We live with that. We try to save them, but not all of them survive. This is another thing that you can do. This guy has a tracheostomy. When you know that the patient is going to be for a long time on mechanical ventilation, for example, and this applies more for polyneuropathies, a nice way to have them on the ventilator with some support, but not asleep all the time. And as I was saying, polyneuropathies are usually the kind of cases a tracheostomy can help you to have the patient awake and being ventilated through the tracheostomy tube. So this makes things a little bit more easy because you can have this patient eating and being awake and with not all the complications of severe rise of propofol, ketamine, a tube in his mouth, more predisposition to aspiration pneumonia. So these are the kind of things that we do on them. No? How to prevent or be ahead of these complications? Just the only thing that you can actually do is to monitor these patients and be ahead, knowing that this can happen. So if I know the CO2 is going to be a problem, I have two options. Either I have a machine that I can measure the CO2, or a blood sample, or I have another machine that can help me with the nasal CO2 that I showed you on the first lecture. If you don't have neither of these, then just look and be more insistent with the breathing pattern of that patient, and just control that more often during the day, okay? And don't forget about that. This is, again, how we use the nasal prompts for the CO2. Neurogenic shock, this also exists, but you don't know or you don't remember this exists until you see this, because it's so strange to see this and the presentation doesn't make any sense, that you can be really shocked when you see a neurogenic shock. So this is related to acute loss of autonomic tone, and always is related to lesions that are up to the thoracic vertebrae number 6. So that's where the most of your sympathetic stimulation is gonna come out. So when, for whatever reason, you have a block of that, your patient can get into a massive vasodilation, and you will see bradycardia with hypotension that will go as well with very warm skin, or with mucous membranes that are looking really congested, which doesn't make any sense in a patient that is hypotensive or is bradycardic. You would expect most of the time those gums or mucous membranes to look pale on those animals. So when this happens, what you will see is a patient that is massively hypotensive with bradycardia and lesions up to T6. I have seen this only twice in my life, but this is very representative of what happens. And the treatment of this is just fluids and vasopressors. You will see that only with fluids you will not get anything better on these animals, and you will need any of them, any of these, either norepi, dopamine, and in very bad cases, adrenaline. So when you have things like this and a patient that needs all of these, imaging of the neck is probably what you are going to need at some point. Either to start with chest X-rays, looking for damage in there, looking more thorough with a history of the patient and see if something makes sense. Perhaps with a CT scan you can find what's happening. Most of them are discs, the ones that I have seen, but it's really important to find out where the cause is, because otherwise you will not fix it. What about pain? Look at this poor little guy. Let's take a look at this one. This Frenchie was trying to sit on his cage, and he would think about that for a while, because every single time that he tried, every time that he tried, he was screaming in pain, no? And this dog had a cervical hernia. This is something that we all see, and it's really sad, no? When you see a dog like this, you have to treat somehow. This dog was already on methadone every 4 hours, zero point 0.3 milligrams per kilo, but methadone was not enough for him. He needed even more, no? What can we do for dogs like this? Don't be shy to give them analgesia, but be careful as well, because opioids can decrease at some point your ventilation capacity. So just try to find a balance for this dog. Sometimes it's not all about opioids, it's just adding different kind of analgesia. You can use ketamine, you can use lidocaine, you can use gabapentin. What I have found as well for dogs is muscle relaxants when they have neck pain can help them. So give them a chance and just not just accommodate with opioids and think that everything is going to be better with methadone because he's already on methadone. So the patient has pain, treat it, right? So this is any combination option of this, it's fine. I mean, just do whatever you want. If you want to use diazepam instead of methocarbamol, it also works. Sometimes they just need to sleep, and get better because the tension of the neck is really bad. But always remember that if that patient is at risk of respiratory depression because of the cervical problem that he has, your therapeutic approach might have some impact on him. Fever. Have you seen patients with a spinal trauma and fever that you cannot explain? So this has happened to me so many times, and we would look up to everything. No, is the IV catheter? Is the urine? Did he have aspiration pneumonia? What the heck is happening? No, until I got to this paper, I was doing cultures of pretty much everything because we didn't know what was happening. And most of the times, what we will find was nothing. It was like, well, I know has fever. That's it, and I don't know how to fix it. The dog looks fine to me. There is nothing on the CBC. There is nothing that I can find to explain this fever. So neurogenic fever is something that we know it happens. We conducted a study in Barcelona. I hope it will be published soon. But we found this as well because it was our battle and our struggle with a neurologist all the time. And the classic reaction of a vet when he finds fever, what is to give antibiotics and slam more antibiotics and more antibiotics. And it was doing nothing for this patient more than creating resistance, no? Or getting urine complications because most of them also have a urinary catheter. So, oops, I'm really bad on time. So this is something that you have to be aware that neurogenic fever also happens in these patients, and it will go away the same way it came to you. So if this is giving problems to the patient, and by problems I mean he's really depressed, he's not eating, he's not feeling comfortable, okay, then you can use some drugs like paracetamol or methimazole, something that will make him feel better. Okay, otherwise there is no reason to fight it. Pancreatitis for these dogs. No many studies, but just one of them showing that dogs with IBDD can have pancreatic, at least the lipase can be high. Okay, this doesn't really correlate in this study with clinical signs, but just think about this. Dogs with bad T3L3 disease like this dog can get into pancreatitis. And especially if you get them hypotensive because you need them to be sedated because they are not doing well in the post-op. So just keep those things in mind because the pancreas needs a normal perfusion, right? Recumbency, and they will lose reflexes, aspiration pneumonia, scalding. So remember to change them, to use towels, to have them comfortable. How can we prevent regurgitation? We have talked about this on the other lectures, so it's pretty much the same. The more depressed he is, the more we push with these drugs. That's it. And to end the lecture, what about the micturition problems? So this was a physiologic review of how we fill the bladder and how we empty the bladder. Basically, there are three nerves: hypogastric, pudendal, and pelvic nerve. So when we have problems between T3 and L3, the problem that we have is that the emptying is going to be messed up, and we cannot really empty the bladder as much as we want. And in those cases, when we have patients with no motor functions and T3, L3 problems, what we do is to place a urinary catheter, as probably you are doing, right? So is this out of risk to place urinary catheter? So no, actually no. And it really depends on how you manage them. And this is something that I like to put on lectures and explain, because for every single day that you keep a urinary catheter in place, even with the best care that you can, in this study, every single day the risk of infection increased by 27%. So be aware of this, because you are going to be using antibiotics. If that patient on top of that develops fever, you are going to add more antibiotics. And at the end, you will end with a pseudomonas that is growing into the bladder, and then you will have another problem that you didn't have at the beginning. So consider, can you place that urinary catheter and keep it clean and do the care that you need for that? And as soon as you can, remove the urinary catheter, okay? That would be the message. Risk of thrombosis, again, these recommendations in thromboprophylaxis, in human medicine, they use it as a routine. In spinal trauma, in veterinary medicine, I have no paper, nothing to show you that we need to do this. And in my in my life, I have not seen so many dogs developing this complication to justify it. But it makes sense to think that perhaps in bad spinal traumas, as the coagulation is messed up, as we have seen on other patients, it could have some role at some point, because these patients are recumbent and definitely the blood flow is going to be compromised. So, conclusion of this: watch out with all the complications that you can have with neurological patients. Most of the care that you have to provide them is just supportive, but be ahead of complications. And take this into consideration. The more complicated the case, the more resources you will need. So don't be afraid to do whatever is necessary for the acute moment, but then definitely think about what is going to come up after, and if the client wants to be referred, then go for it. Well, thank you very much for the morning and for being here. Has been a pleasure.